Lisa Henderson's morning had been consumed by back-to-back meetings at Medicare Pharmacy's new regional headquarters in Nashville. As the newly appointed CEO of one of the Southeast's largest pharmacy chains, she'd spent the past 2 weeks since her appointment traveling between locations, meeting with staff, and planning the integration of recently acquired pharmacy networks. At 38, Lisa had climbed from pharmacist to district manager to VP of operations to CEO through a combination of clinical expertise, business acumen, and relentless work ethic. Her appointment had made headlines in pharmaceutical trade publications. First Black female CEO leads major pharmacy chain. Today's agenda included visiting several Nashville area locations that had been part of a recent acquisition. Medicare had purchased regional health pharmacies 3 months ago, bringing 47 locations under Medicare's umbrella. The acquisition was still being integrated, with many staff members unaware of the corporate ownership changes. But first, Lisa needed to handle a personal matter. She'd injured her shoulder 2 days ago, moving furniture in her new apartment. Her doctor had prescribed a moderate pain medication and muscle relaxer to help her through the acute inflammation phase. The prescription was completely routine. 15 tablets of a low-dose opioid analgesic, standard treatment for temporary musculoskeletal pain. Lisa pulled into the parking lot of Williams Pharmacy, one of the recently acquired locations in a middle-class Nashville neighborhood. She'd planned to fill her prescription here while conducting an unannounced evaluation of customer service and operations. Walking into the pharmacy at 2:17 p.m., Lisa joined a short line at the prescription counter. She observed the layout, noting outdated signage, cluttered aisles, and a pharmacy consultation area that needed renovation, mental notes for improvement. When her turn came, she approached the counter where a pharmacist in his early 60s stood reviewing prescriptions. His name badge read, "Donald Green, PharmD. Good afternoon. I need to fill this prescription." Lisa handed him the written prescription from her doctor along with her insurance card and driver's license. Green took the prescription, and immediately his expression shifted. He looked from the prescription to Lisa, his eyes narrowing with suspicion. "This is for hydrocodone," he said, his tone accusatory rather than informational. "Yes, for a shoulder injury. My doctor prescribed it yesterday." Green studied the prescription more closely, then looked at Lisa again with undisguised skepticism. "How did you injure your shoulder?" "Moving furniture. It's a muscle strain with inflammation." "Uh-huh." Green's tone suggested he didn't believe her. "And your doctor thought you needed an opioid for that?" Lisa felt her professional instincts activating. She'd been a practicing pharmacist for 15 years before moving into management. She knew appropriate prescribing protocols, and she knew this prescription was completely standard. It's a legitimate medical prescription from a licensed physician for appropriate pain management. Is there a problem? Green set the prescription down on the counter. "The problem, Miss Henderson, is that we have an opioid crisis in this country. Pharmacists have a responsibility to ensure medications aren't being abused or diverted. I understand that responsibility. I'm also a pharmacist. This prescription is for 15 tablets of a low-dose medication for acute injury. It's textbook appropriate use." Green's eyebrows raised. "You're a pharmacist?" "Yes. PharmD from the University of Tennessee, licensed in 3 states. Rather than easing his suspicion, this information seemed to increase it. "Then you should know that claiming to be a healthcare professional to obtain controlled substances is a serious offense." Lisa stared at him, unable to believe what she was hearing. "I'm not claiming anything. I am a pharmacist, and I'm not obtaining controlled substances. I'm filling a legitimate prescription from my doctor." "Miss Henderson, I've been a pharmacist for 37 years. I know when something doesn't look right." A young woman coming in with a prescription for pain medication, claiming professional credentials. It raises red flags. Other customers in line were listening now. Lisa felt humiliation mixing with her anger. "What specifically looks wrong?" "My prescription is properly written by a licensed MD. My insurance will verify the claim. My medical history will show no pattern of controlled substance use." "What's the actual issue?" Green leaned on the counter. "The issue is that I'm not comfortable filling this prescription. I have professional discretion to refuse dispensing when I suspect misuse or diversion. Based on what evidence? Based on my professional judgment." Lisa pulled out her phone. "Let me show you my pharmacy license." She navigated to her professional credentials on the State Licensing Board website, showing her active PharmD license and her clean disciplinary record. Green glanced at it dismissively. Anyone can create fake websites. I'm not filling this prescription, Miss Henderson. If you have a legitimate medical need, I suggest you visit an urgent care clinic and have them treat you there under observation. Under observation? You think I'm going to inject hydrocodone pills? I think people with substance abuse problems are resourceful and manipulative, and I'm not going to be complicit in addiction. Lisa's voice remained calm, but her words were precise. You're refusing to fill a valid prescription from a licensed physician to a patient with documented injury and no history of substance abuse. You're making this decision based on what exactly? Because I'm young? Because I'm black? What criteria are you actually using? Green's face flushed. Don't you dare play the race card. This has nothing to do with race and everything to do with responsible pharmacy practice. Then explain why my race, age and appearance are the only factors you've assessed. You haven't checked my prescription history. You haven't called my doctor. You haven't reviewed my insurance records. You've simply looked at me and decided I'm drug seeking. I've made my decision. Now please step aside. There are other customers waiting. Lisa didn't move. I want to speak to your supervisor. I'm the supervising pharmacist on duty. My decision is final. Then I want corporate contact information. I'm filing a formal complaint. Green pulled out a business card and handed it to her with a smirk. Feel free to complain to regional health pharmacies. They support their pharmacists in making appropriate clinical judgments. Lisa looked at the card, which listed the old company name that Medicare had acquired. She almost smiled. Green had no idea that regional health pharmacies no longer existed as an independent entity, that it was now part of Medicare, or that he was refusing service to the CEO of his own company. I'll be sure to contact them, Lisa said. She took a photo of her prescription before Green could object, then left the pharmacy. In her car, Lisa immediately called her Chief Operating Officer, James Rodriguez. James, I need you to pull employment and complaint records for Williams Pharmacy in Nashville, specifically for pharmacist Donald Green, and I need our legal team to review protocols for pharmacist refusal of legitimate prescriptions. What happened? Lisa explained the situation, her voice tight with controlled fury. James listened, his anger matching hers. He refused your prescription. Lisa, that's medical discrimination, and possibly racial profiling. It's definitely profiling. I want to know if he has a pattern. Pull prescription refusal data from his location. Cross-reference with patient demographics if we have that data. I want to know how many legitimate prescriptions he's refused and who those patients were. On it. What are you going to do? I'm going to get my prescription filled elsewhere. Then I'm going to pay another visit to Williams Pharmacy. This time Mr. Green is going to learn exactly who he refused service to. By 4:30 p.m., Lisa had her prescription filled at a different Medicare location, where the pharmacist processed it without issue in under 10 minutes. She'd also received preliminary data from James that was deeply troubling. Over the past 3 years at Williams Pharmacy, Donald Green had personally refused to fill 127 prescriptions. Of those refusals, 38 involved other medications, contraceptives, HIV medications, psychiatric medications. When cross-referenced with available demographic data, Williams' FEDI-3 refusals involved black patients, 57%, 21 involved Latino patients, 17%. More troubling, Green had refused 23 prescriptions for birth control or emergency contraception, citing moral objections. He'd refused 12 prescriptions for HIV medications, with notes suggesting he'd questioned patients' sexual behavior, and he'd refused numerous psychiatric medications with judgmental comments about mental health treatment. The data showed a pharmacist who was using his professional discretion not to prevent genuine abuse, but to impose his personal moral judgments and racial biases on patients. Lisa called James back. Schedule an emergency meeting at Williams Pharmacy for 5 p.m. today. I want the store manager present, and have our legal counsel on standby. Green is being terminated tonight. At 4:57 p.m., Lisa walked back into Williams Pharmacy. The store manager, a nervous young woman named Ashley Martin, met her at the entrance. Are you Miss Henderson? Mr. Rodriguez called and said you're with corporate. I'm Lisa Henderson, CEO of Medicare Pharmacies. We need to speak with Donald Green immediately. In private. Ashley's eyes widened. The CEO? Oh my God. Yes, of course. Let me get Mr. Green from the pharmacy. They moved to a back office area. Green entered, looking irritated at being pulled from his duties. His irritation turned to confusion when he saw Lisa. You again? What's this about? Lisa remained standing. Mr. Green, I'm Lisa Henderson, CEO of Medicare Pharmacies. Medicare acquired regional health pharmacies 3 months ago. That means I own this pharmacy, which means I'm your employer. Green's face went pale. You're what? I'm the CEO of the company that owns this pharmacy. The same person you refused service to this afternoon. The same person you accused of drug seeking without evidence. The same person you lectured about substance abuse despite having no basis for your concerns. Ashley Martin looked like she wanted to disappear. Green stammered. I didn't know you didn't identify yourself. I didn't need to identify myself. I was a customer with a legitimate prescription. But your refusal prompted me to investigate your prescribing patterns. Mr. Green, in the past 3 years you've refused 127 prescriptions. 73 of those refusals involved black patients in a neighborhood that's only 35% black. You've imposed your personal moral judgments on patients seeking contraception, HIV medications, and psychiatric care. You've created barriers to legitimate medical treatment based on your biases. I was exercising professional discretion. You were discriminating against patients, and you were doing it systematically, creating disparate impact on patients of color and other vulnerable populations. Lisa pulled out printed data. Here's a white patient, 62 years old, prescribed the exact same medication I was prescribed, for the same indication by the same doctor. You filled it without question. Here's another black patient, 34, same medication, same doctor. You refused, citing concerns about abuse potential. What's the difference between these patients? Green had no answer. The difference is race, Mr. Green. You saw me, a black woman requesting pain medication, and assumed drug seeking. You saw my credentials and assumed I was lying. You made medical decisions based on racial profiling rather than clinical evidence. That's not fair. I was trying to prevent abuse by refusing legitimate prescriptions to patients of color at twice the rate you refuse them to white patients. That's not preventing abuse. That's practicing racist medicine. Lisa's voice was firm but controlled. Donald Green, your employment with Medicare Pharmacies is terminated effective immediately for discriminatory patient care practices. You'll be paid through today. Your pharmacy license will be reported to the Tennessee Board of Pharmacy for investigation, and you have 15 minutes to collect your personal belongings before security escorts you from the premises. Green's shock turned to anger. You can't fire me. I've been here for 18 years. I have tenure. The Pharmacist Union. Tennessee is an at-will employment state, and discriminatory conduct is grounds for immediate termination, regardless of tenure. Your union can review the data I've compiled. I'm confident they'll understand. This is retaliation. You're firing me because I refused your prescription. I'm firing you because you've refused 127 prescriptions with clear patterns of racial and demographic bias. The fact that I personally experienced your discrimination simply brought the pattern to my attention. The termination is based on 3 years of documented discriminatory conduct. Lisa nodded to Ashley. Please escort Mr. Green to collect his belongings. We'll have a temporary pharmacist here within the hour to cover the evening shift. As Green was led out, still protesting, Lisa sat with Ashley to explain what would happen next. Medicare will be conducting a comprehensive review of all Williams Pharmacy locations. We'll be implementing new protocols to prevent discriminatory prescription refusals. All pharmacists will receive mandatory training on cultural competence and appropriate use of professional discretion. And we'll be establishing an appeals process for patients who believe they've been unfairly denied medications. Ashley nodded, still processing everything. I had no idea Mr. Green was doing this. I mean, I knew he refused prescriptions sometimes, but I didn't realize there was a pattern. That's part of the problem. Individual acts of discrimination can seem like isolated incidents. It takes data analysis to reveal patterns. That's why we'll be tracking refusal rates and reviewing them regularly for disparities. Over the next 3 months, Medicare conducted a system-wide audit of prescription refusals across all 47 former regional health locations. The findings were sobering. Donald Green wasn't the only pharmacist practicing discriminatory medicine. 7 other pharmacists showed similar patterns, though none as extreme as Green's. Medicare implemented sweeping reforms. 1 point. Refusal protocol. Clear criteria for when pharmacists could refuse prescriptions, requiring documentation of specific clinical concerns rather than subjective judgments. 2. Oversight review. Monthly audits of refusal patterns, with investigations triggered when refusal rates showed demographic disparities. 3. Patient appeals. Simple process for patients to appeal refusals, with independent review by clinical pharmacists not involved in the original decision. 4. Cultural competence. Mandatory training on implicit bias, health equity, and culturally appropriate patient care. 5. Moral objection limits. While respecting genuine religious objections, pharmacists had to refer patients to another provider immediately rather than simply refusing service. 6. Data transparency, annual public reporting on prescription refusal rates and patient satisfaction scores by location. The reforms cost $3.2 million to implement, but resulted in dramatic improvements in patient satisfaction and health equity outcomes. Patients who'd previously been refused medications by Green and other biased pharmacists were contacted and offered apologies, assistance in filling their prescriptions, and information about Medicare's complaint process if they wanted to share their experiences. 19 patients chose to share their stories. Marcus Williams, a black patient with chronic pain. Green refused my prescription 5 times over 2 years. Each time he lectured me about opioid addiction and suggested I was exaggerating my pain. Meanwhile, I have documented degenerative disc disease and my pain management was appropriate. I suffered needlessly because he assumed a black man with pain medication was an addict. Jennifer Lopez, a Latina patient seeking emergency contraception. He refused to fill my prescription and gave me a lecture about sexual morality. I was 23 years old, had a condom break and needed Plan B. His personal beliefs shouldn't have prevented me from accessing legal medication. Thomas Chen, a patient living with HIV. Green asked invasive questions about my sexual orientation and partners when I tried to fill my antiretroviral prescription. He made me feel ashamed for having HIV. I switched to a different pharmacy to avoid his judgment. These testimonies, along with Green's refusal data, were submitted to the Tennessee Board of Pharmacy. The board launched its own investigation into Green's practice. 6 months after his termination from Medicare, the Tennessee Board of Pharmacy suspended Donald Green's license for 2 years for discriminatory patient care practices. The suspension meant he couldn't work as a pharmacist anywhere in Tennessee during that period. Green filed an appeal, arguing that pharmacists had professional discretion and First Amendment rights. The board's decision was upheld. The ruling stated, professional discretion must be exercised based on clinical judgment, not racial bias or personal moral objections that deny patients access to legal, medically appropriate treatments. Mr. Green's pattern of refusals showed clear demographic disparities inconsistent with evidence-based practice. 1 year after the incident, Lisa was invited to speak at the National Community Pharmacists Association conference about equity in pharmacy practice. She shared her personal experience and Medicare's subsequent reforms. When Donald Green looked at me, he didn't see a CEO, a fellow pharmacist, or a patient with a legitimate medical need. He saw a young black woman and made assumptions based on stereotypes about drug-seeking behavior. But I had resources and power. I was the CEO of his company. I could investigate, terminate, and reform. Most of the patients Green discriminated against over the years didn't have that power. They just experienced the denial of care, the humiliation, the barriers to treatment, and they had no recourse. That's why data matters. Green's individual acts of bias seemed like professional judgments to him. But when we analyzed the data, the pattern was undeniable. He was systematically denying care to patients of color while serving white patients with identical medical needs, Lisa continued. Pharmacists have important gatekeeping responsibilities. We prevent drug interactions, identify potentially inappropriate prescribing, and yes, help combat prescription drug abuse. But those responsibilities must be exercised equitably. If you're refusing prescriptions for opioids to black patients at twice the rate you refuse them to white patients, that's not fighting abuse, that's racism. The question every pharmacist must ask themselves, are my professional judgments based on clinical evidence or on biases about who deserves treatment? Because bias in healthcare isn't just unprofessional, it's deadly. It creates barriers to care, worsens health disparities, and violates our fundamental obligation to serve all patients with equal compassion. The speech went viral in pharmaceutical communities. Several other pharmacy chains reached out to Medicare to learn about their refusal monitoring protocols and equity training programs. 3 years after the incident, Medicare's patient satisfaction scores had increased by 23%. Complaints about discriminatory treatment had dropped by 87%. And the company had become recognized as a leader in health equity within the pharmacy industry. Donald Green, after serving his 2-year license suspension, attempted to return to pharmacy practice. He found that no major chains would hire him. His discriminatory practices were well documented, and pharmacy employers were increasingly sensitive to equity issues following several high-profile lawsuits. Green eventually found part-time work at a small independent pharmacy in rural Tennessee, earning a fraction of his previous salary. In a later interview, Green offered what seemed like genuine reflection. I thought I was being a good pharmacist by being cautious about controlled substances. I thought I was protecting patients and my license, but I was really just enforcing my own prejudices about who looked like they might abuse drugs. Lisa Henderson was a CEO and a pharmacist with a completely legitimate prescription. I refused her based on nothing but her appearance. That was wrong, and the data showed I'd been doing it to other patients for years. I destroyed people's trust in healthcare, created barriers to treatment, and ultimately destroyed my own career because I couldn't see past my biases.
5 years after the incident, Lisa remained CEO of Medicare, which had continued to grow and acquire new pharmacy locations. Under her leadership, the company had become the first major pharmacy chain to achieve health equity certification from the National Association of Chain Drugstores. Medicare's equity initiatives had expanded beyond prescription refusals to include diverse hiring, multilingual services, community health programs in underserved neighborhoods, and partnerships with organizations addressing social determinants of health. The changes weren't solely attributable to Lisa's experience with Green, but that incident had catalyzed a corporate commitment to equity that permeated every aspect of Medicare's operations. Lisa's shoulder had healed long ago, requiring only a few days of the medication Green had refused. But the impact of that refusal, the discrimination she'd experienced, and the systemic changes it prompted had lasting effects on healthcare access for thousands of patients. 10 years after the incident, Lisa received the National Healthcare Equity Leadership Award. In her acceptance speech, she referenced the Williams Pharmacy incident. "A decade ago, a pharmacist refused to fill my prescription because he looked at me and saw his stereotypes rather than a patient with a legitimate medical need. That discrimination was painful and infuriating, but it also gave me clarity about how my position as CEO could be used. I could have quietly filled my prescription elsewhere and forgotten about it. Instead, I investigated, discovered a pattern of discrimination affecting dozens of patients, and used my authority to create change. Not just firing one biased pharmacist, but transforming an entire company's approach to health equity. That's what power is for. Not personal advancement or revenge, but creating systems where everyone receives equitable care regardless of race, income, or social status. Donald Green discriminated against me, but I wasn't his only victim. Using my experience to protect future patients, that's the real victory." The lesson extended beyond Medicare. Across the pharmacy industry, companies began tracking prescription refusal patterns, training pharmacists on bias, and creating accountability mechanisms. Federal regulations were proposed requiring demographic reporting of prescription refusals to identify discriminatory practices. And in pharmacies across America, the story of Donald Green became a cautionary tale. The pharmacist who let his biases guide his professional judgment and paid the ultimate career price when he discriminated against someone with the power to hold him accountable.
Thank you very much for listening. Please let us know what you think of this story in the comments. Don't forget to like the video and subscribe to the channel. Turn on notifications so you don't miss any other videos.